Good afternoon, Mr. Chairman, ladies and gentlemen. I would like to give you our work in cell therapy at the Bangkok Heart Hospital. And the talk will be divided into two sessions, but now I can continue in one session. And first, we will give you some introduction about the stem cell. Some of you may be familiar with this, some are not. So I will give you a little background about the cell type and delivery method, clinical trial, and then we give you our experience at the end. Sometimes we forgot the heart pathology is developing from insult. After the insult, there will be a lot of change in myocardium, and there also neurohormonal change in the whole body, and gene expression cause cell apoptosis, and then it progress. It's not stop after the insult is stopped. The progress of disease is not stopped. It's still continuing, and then we need some kind of treatment like LVAD, CRTD to help the patient, but it's not answer the problem with the cell itself. So what we try to do is to give the patient back the cell that they need. They actually need the cell, not need the mechanical device. And so the cell will come maybe at the end. Right now, it come at the end, okay? So stem cells have three properties. They have high differentiation potential. They can cell renew, and then they give specialized type of cells. And we can study in small animal like Hydra, and then we know the H gene control the regeneration of the cell in this small animal. And then we can study at the fish. This fish can be regenerate the cell, and the control transcription factor they studied, they find out the Notch gene control the regeneration property of this. And some animal also, bigger animal like salamander can regenerate their leg, their eye, their cornea. And this transforming growth factor beta 5 control that kind of development. And for the stem cell in human, they start from the cell in the blood transfusion in 1818, and then they'll develop mostly in the hematology area. But in the last 10 years, we have some embryonic stem cells. Then we have a lot of more study in the stem cell for other disease. And this is the time when the medical product is developed. It takes a lot of time. In the past, penicillin take 13 years, monoclonal antibody take 11 years, and recombinant protein take 9 years to develop some kind of product that can be used. Also the stem cell, and this is 3 persons that they won a Nobel Prize in the stem cell subject. So we can have the stem cell divided into 2 type of cell, embryonic stem cell and somatic stem cell. Somatic is adult stem cell, and the adult stem cell, we can have a hematopoietic stem cell and mesenchymal stem cell. And for our experience, we use peripheral blood stem cell, the hematologic stem cell. And now they can develop multipotent stem cell, pluripotent stem cell from the skin. Now we call it induced pluripotent stem cell. So they take skin and then they stimulate the gene inside. So the development of the cell is backward to more premature, and we call it induced pluripotent stem cell. And if you can do it, you can produce animal from that induced pluripotent stem cell. But the animal is not normal. They'll live, the life is shorter than normal animal. And for the heart, you can make the induced pluripotent stem cell to contract like cardiomyocyte. And you can treat the patient maybe in the future. This is in animal, they can treat sickle cell anemia in animal with IPS, successful. And for the heart, they can also treat with induced pluripotent stem cell. And this is a little bit different from our group. They use the patch and put the cell and put the patch on top of the heart to make the cell stay longer in the heart. And maybe it's a new way to treat it. And then the Korean group can do the stem cell, induced pluripotent stem cell without gene manipulation. But they still need to use a protein from the embryonic stem cell. So they eliminate the viral vector to produce the cells by putting only protein from the embryonic cell to stimulate. So this is a picture of the different kind of cell, range from more potent embryonic stem cell to less potent. And in the heart, we have a cardiac stem cell too. So you can have very strong stem cell and less strong stem cell. And in the brain, we have cell that it can divide. And this is the mouse make it spinal injury, and then put the stem cell from human into this mouse. And 12 weeks later, the mouse can move the leg, can move some of the muscle. And this to show you some neural stem cell that can cell renew. So what we think is not possible is possible, okay? Now, in intestine, there's a stem cell too. In the heart, we have stem cell, but it's small number, cannot repair our big myocardial infarction. And you can see from this, the cell can be divided, cardiac stem cell. So today we focus on the stem cell from peripheral blood, okay? And the peripheral blood stem cell is first described by Asahara, the Japanese scientist. He found that there are some cells that's circulating in your blood that can differentiate into endothelial cell, make angiogenesis. And you can mobilize the stem cell by, you take it from the bone marrow. Bone marrow has many stem cells, also mesenchymal stem cell and blood stem cell. And you can do injection with the GCSF, coronary stimulating factor, to make the bone marrow release the cell to peripheral blood, and then you can harvest it. Or you can take it from peripheral blood. There are small number of stem cell is going in your bloodstream, and then you can make it expansion outside the body, and then you can transplant it back. And when you have ischemic, when you do surgery, you do ischemic precondition, they'll stimulate the stem cell too. Or you can do a local injury to make the stem cell is released. And this is to show you that stem cell is related to outcome of the patient. They follow up patient coronary artery disease, 500 patients, and then they found patient with higher number of endothelial progenitor cells have a better survival, better outcome. And this is to show you the cell from peripheral blood mostly is CD34. It can be differentiated into the endothelial cell. And it can be differentiated into cardiomyocyte too. And it can be differentiated into cardiomyocyte in different group of scientists they can functional like a normal cardiomyocyte from the peripheral blood stem cell, EPC. And this is show you in a bigger animal, in monkey, that may be closely to human, that the cell from peripheral blood bone marrow can differentiate and make secrete function of VEGF and significant increased angiogenesis in the myocardium after the injection. So this is a capillary density increase after the injection compared with the control. And this is another picture to show you bone marrow stem cell. When you transplant into heart muscle, it can be function. And this is another different study. They show the bone marrow can differentiate into cardiomyocyte-like cell. And they take from the sternal bone marrow, sternal bone, when they did the bypass surgery, and they take this, and the cell can be differentiated into cardiomyocyte, demonstrated by immunohistochemistry and protein by RT-PCR analysis. This is show you that the cell can be fused with their own cell, cardiomyocyte. So today we do the peripheral blood isolation and then culture and then inject back into the heart. So how to inject them? There's maybe 4 major different ways to do it. You can do number A, injection like this, direct into the muscle like we did. We can do the catheter inside, direct injection into the heart muscle, or you can do the catheter to the coronary artery, or you can go backward to inject into the vein. We call it lateral perfusion. For the IV injection is maybe doesn't work right now because the cell just go somewhere else, not go to the heart. And intramyocardium and intracoronary have different advantage and disadvantage. And we are surgeons, so we do myocardium injection. Maybe this have more cell retention than the intracoronary injection. The disadvantage that is you have to open the chest to inject. And if you don't want to open the chest, you can do the catheter, but the catheter to go inside the heart, inject direct into the heart muscle, is a little bit complicated, and it needs special catheter. It needs electromechanical mapping to inject into the right position, right target. Or you can inject through the vein. You go to coronary vein, and then you can inject puncture from vein outside to the muscle. And this is a little bit complicated. And when we compare the delivery method, and we compare intracoronary, intramyocardium, and retrograde coronary sinus in the animal, okay, most of the cells go to the lung in every method, okay? Most of the cells go to the lung in the red bar, and this is the intramyocardium have more cell retention than intracoronary or by the retrograde vein. So Like now we think the intramyocardial injection have a better cell retention than the other, so we going to do the intramyocardial cell injection in some patients that they really cannot do the surgery. Then we do coronary artery injection. And this is another evidence to show you that the intracoronary injection is not very good. When you inject into, this is a human, and they tag the cell with the radionuclide. After injection, they found only 5% of the cell in the heart. And after 18 hours, only 1% of the cell is in the heart. So the rest is go somewhere else. So go to spleen and maybe excrete somewhere else, not in the heart. So how come this cell can repair the heart? So many studies published in journal, half maybe intracoronary and intramyocardium. Some of them show it work very well. Some of them doesn't show the cell is function. And if you want to do review, you go to this article. You can read the 10 years intracoronary and intramyocardial bone marrow cell injection. This is quite good paper. And there's summary of everything: acute, ischemic, and dilated cardiomyopathy. And one study showed the survival after the cell injection is much better than the control. And this is very good survival. But when you compare the study, then a lot of different method, a lot of different patients, so different can be, outcome can be very different. If you choose different cell, different type of patient, different injection, and how long the disease is progress, graft survival, transdifferentiation, many problems we still need to solve the problem. And this is very new that the group, Doris Taylor, that she took the heart and decellulized the cell, and then they inject the stem cell back into the heart. So then the heart can back complete function again, decellulized, and then inject the cell. The cell, the heart, can contract again after. This is regenerate the whole heart, okay? They remove the cell. After remove the cell, only the scaffold of the heart is remain, and then they inject the stem cell, and they make the cell beat again. And to make a heart is very complicated. It is not a simple task. You need angiogenesis, you need cardiomyogenesis, you need a pacemaker. You need everything to make the heart work. And in summary, the first part, we think the cell regeneration is very rapid progress field, and we still need a lot of basic questions to be answered. A lot of basic science need to be carried out to give you a cell that maybe help the heart better. So I want to go to the next. But anyhow, we have to balance between everything. The maybe ethical too, because there some we involved with the embryonic stem cell, so we have to be very careful with the embryonic stem cell. But at the Bangkok Heart Hospital, we do very safe procedure. We use the peripheral blood stem cell. This is not involved in any embryonic stem cell. We took 250 cc of blood, and then we separate cell, and then we expand it. And the cell preparation is described in this journal by Dr. Pollard in the British Journal of Hematology. So we take the blood and we separate multipotent stem cell. We culture them with the VEGF and heparin for 5 days. And then we have this cell we call angiogenic cell precursor that have this cell marker, CD34, CD133, and different marker for the endothelial cells. And then this cell can secrete interleukin-6, vascular endothelial growth factor, and angiogenin, and form tube-like tissue in vitro. At the end of the culture, we have about 40 million of cells and 96% viability after the culture. And we did this cell in animal by the group in Toronto General Hospital. They did the animal study for us, and they can show the scar is reduced by particular cell, and then there's angiogenesis in this animal. This will show you the picture. Compare with the control. The scar is reduced, and the cell is making angiogenesis. And we first start our project with the University of Pittsburgh. And we take patient ischemic cardiomyopathy, dilated cardiomyopathy, and all of the patients have to have angiogram before to make sure the artery is okay, is open, and ejection fraction is less than 40, functional class 3 and 4. And then we exclude the patient with the blood transfusion within 1 month, malignancy within 3 years, and all the blood infection. And this is a pre-op and post-op test. And then we inject the cell. Some patients we inject the cell combined with the bypass surgery because the patient still have a blocked artery. You can do by thoracoscope if you do only the cell injection. And this is the result from May 2005 to February 2010. We have 126 patients, age between around 60 years old. And we have combined the cell with the bypass surgery, which we do it off pump, 34% of patients. This is in ischemic cardiomyopathy. In dilated cardiomyopathy, we do only cell injection. And we assess the MRI you saw this morning, before and after. You can see a very big heart. And we also measure the scar area, infarction area before and after. And for the safety issue, about 4% mortality in both group of the patient. And the functional class is reduced after the cell injection. Both group significant. And both group have the left ventricular ejection fraction increase, and it's more increase in the ischemic cardiomyopathy patient. And you can see very wide range of improvement. Okay, so it's a lot of variability in this patient. And we have 25 patients have pre and post-op cardiac MRI that we able to do MRI because some patients have defibrillator, cannot do the MRI before surgery. We have only 25 that we have pre and post. And we found that the infarction area is reduced by 10% significant, and the end-diastolic and systolic volume is reduced. And this quality of life is improved in both DCM and ICM. And conclusion in the first part, we can say that this cell is safe, okay? No ventricular arrhythmia. Actually, one patient have intractable ventricular arrhythmia before surgery. After injection, the patient better and she got less ventricular arrhythmia afterward. And the left ventricular ejection fraction, functional class, 6-minute walk, and quality of life will improve. And then we report in several journal and conference. And we go to the next step. We want to be more more scientific. Then we make a control. Okay, we calculate the difference. We want about 10%, and then we can find out the number of patients that we need for the study. About 23 should be enough with 95% confidence and power of 99. And then we compare the cell with the medicine. And we report this at the American Heart meeting at Council of Basic Cardiovascular Science long time ago. We compare the group and we find out that the cell injection group is better than the medical treatment alone. I have to go very fast. This we compare the cell with the bypass surgery. So patients have the cell injection, and another control, 25 patients only bypass alone. And you can see the only cell injection improve the heart function 8%. With CABG alone, it's improved only 3.3%, and it's not significant. And the stem cell group have a significant improvement in cell ejection fraction. And this is dilated cardiomyopathy patient. We compared 35 and 17 patients. And the cell injection for dilated cardiomyopathy is better than the medical treatment alone. And then we saw a lot of variability of the result in the LVEF improvement. So we want to find out which patient we should inject, which patient we should not. And then we look at our database, 94 patients, and we have cell injection, and the rest have no cell injection. Some of them have medical treatment alone. Some of them have CBG alone. This is for only ischemic cardiomyopathy patient. And we find out that the predictor of the ejection fraction that improved more than 5% is only the ejection fraction pre-op. If you have low ejection fraction pre-op, then the chance that you have higher ejection fraction is post-op better, and the cell injection is predictor of improvement. And we just report our midterm result in EACTS in Portuguese, Lisbon, and last month. And we follow up the patient, 3,000 patient months, and we have overall death is 14.5 per 1,000 per month. Overall cardiac death is 43, and 2 patients die from cancer. And this is to look at the survival curve. The 4-year survival is unfortunately is not very high. It's only 55%. This is for DCM and ICM together. And to do the clock ligation analysis, we find out the pre-op ejection fraction is very determine the outcome of the patient. If they have very low ejection fraction pre-op, the survival is not very good. If you drop your ejection fraction 5%, your chance that you die is 1.6 times higher than better ejection fraction. And this is survival curve. If you low ejection fraction pre-op, very low, I mean less than 25%, the chance that you die is higher than you have a better ejection fraction pre-op. So we might want to do the patient earlier than leave it too long, very low ejection fraction. And DCM, the ICM overall is not different. And cell injection with bypass surgery, all the same. And we think the ejection fraction pre-op is very important. And if you compare the result, the cell injection in the blue, and then you can compare with the gold standard heart transplantation with the LVAD and transplantation. The LVAD and transplantation is better long term. We have not very good midterm outcome in this patient. So you maybe want to do something here. Before maybe 2 years is better, but after it's reduced. So you might want another injection, or you want to do something here. So the cell function is not last very long. When you compare with the SVR have worse outcome than the cell injection in the early stage. When you compare with the ICD, maybe some different patient, maybe ICD patient have a better ejection fraction, so you cannot really compare it. But overall, if you have cell injection, it's better than you do nothing. Better than you leave the patient alone, remain on the waiting list. It's not very good to the patient. So implication of this, we can say that cell injection enhance the functional class, left ventricular ejection fraction, and it may be useful for additional treatment on top of the medical treatment. And cell injection maybe remove some of the patients that need AICD defibrillator or heart transplant. And next generation of cell maybe improve outcome of the heart failure patient. And this I have to acknowledge my boss. He passed away last year, and he initiated and pioneered this project, Dr. Alom. And if you miss something, then you can look at this textbook, just published several months ago in this textbook, chapter 17. The important thing is to do persistent. If you stop it, maybe it's not so good. So you have to do, keep going.
Collaboration with the ICMR, Indian Institute of Immunohematology, Mumbai, and a scientist from UK whose brain thought was this, she developed a new technique which is a little different than what you have used, as I mentioned earlier to you. We were using retro-differentiation technique of peripheral mononuclear cells of the patient using monoclonal antibody CR343. Basically, this study was used for patients with aplastic anemia, and we had the protocol where we could convert these cells into cardiac myocytes, to neuronal cells, and they were subsequently used in thalassemia also and diabetes. 2 of the 4 patients which we had studied and where these cells were infused have lived till today. Out of 4, 2 of aplastic anemia. That's quite a rewarding thing. But our apprehension is that these stem cells are, as you mentioned, are pluripotent cells. We are not sure what course they may take ultimately. If you take the adult stem cells, they may not engraft fully, or if they do engraft, they may not proliferate. So these are the 2 dilemmas. And I think it's a very wide field, and we have to wait and watch how things are. Thank you.
Thank you for the comment. As I said, there's different cell type, different method that they use to improve the cell retention in the heart. Maybe the new technique, maybe use the patch. So you put the cell in the patch and put the patch to the heart, so the cell release to the heart better longer time. Maybe it's help the heart better, but now still developing. And different cell more potent than the cell that we use now. But at least we have demonstrated the cell that we use is safe, and maybe it helps some of the patients. Later on, after this, maybe you can use more potent cell, and you can inject 2 times, 3 times.